Our next speaker is Dr. Michael Nieder from the Moffitt Cancer Center and Research Institute. Dr. Nieder is the inpatient medical director and fellowship director at the BMT program at the Moffitt Cancer Center in Tampa, Florida. He practiced pediatric hematology, oncology, and BMT for 23 years and has been in the adult BMT world for the past 3 years. He is also the vice chair of the Pediatric Blood and Marrow Transplant Consortium. His area of interest is supportive care studies for patients undergoing transplants. He is currently the PI of a protocol utilizing probiotics for patients undergoing transplant. Today, he will be discussing the transplant nuances of patients with disorders of the immune system. Welcome.
Thank you. So good morning, and apologies to those of you who thought you were getting Lisa Filipovich, who couldn't be with us today. So today I wanted to talk briefly about immunodeficiencies and disorders of immunodysregulation in patients and who's going to benefit from transplant. The approach, I think, is important because it's very, very different than the usual approach for patients with leukemias, lymphomas, and other malignant disorders. So this is a list of the most common disorders that are amenable to hematopoietic stem cell transplantation. And I'm not going to go through all of these in a 25-minute period because I'd have to talk even faster than 160 words a second. But I will touch on some of these. Perhaps you have had patients with some of the disorders that are listed up here that are rarer, and perhaps some of these diagnoses are new to you. If you look at a category of immune disorders treated with transplant, there is the category of the absent T and B lymphocytes that we know as SCIDs, and this, of course, is the most common immunodeficiency for which transplant is available. There are disorders of defective T lymphocytes, so Wiskott-aldrich is certainly something that is high on the list of things we transplant. Probably most of you have not seen patients with hyper-IgM syndrome. And then, of course, this category of the dysfunctional, I think all of you have heard of patients with HLH, whether or not it be secondary to some of the other malignant disorders, which is rare in pediatrics but more common in adults, or secondary to some of these other immune disorders. And lastly, obviously, those patients with severe congenital neutropenia that we used to call Kostmans, and some of the rare things, or chronic granulomatous disease. So I imagine that those of you in the room that do have programs that treat immunodeficiencies, you have probably seen almost everything on this list, and these are the more common ones. So there are some primary health concerns. Obviously, these patients are going to die of an infection if they're not transplanted. And as we know, one of the most common complications of our transplantation procedures are infections, so it almost is counterintuitive. Those patients that do survive outside of the SCIDs group often succumb to autoimmunity or malignancy. Some of these patients actually have a predilection for HLH. For instance, those patients with Griscelli syndrome, some of the lymphomas, X-linked disorders. And obviously all these patients pretty much have death in childhood. Now what I'm not covering today is this combined immunodeficiency disorders which do actually survive to adulthood. So if you look at transplant disorders in Europe, because Europe has a pretty good database from all the different centers, you can see that basically SCID is the most common thing that is transplanted, and about half of these disorders that are reported on these databases are in fact SCIDs. And if you look at what the outcome of these transplants is in some of these European centers, you see that when you combine all these different ones and all these different methods in this 24-year period, that the survival is fairly good, but certainly not as high as some of these disorders that we see today. I should also point out that within these disorders, especially SCIDs, that SCIDs is really made up of about 40 different genetic disorders, and they have very different outcomes depending on which of those disorders that you're talking about. So when we're looking at stem cell sources, obviously family member donors are preferred, and for a number of these disorders, you actually don't want to have somebody who's a carrier for some of them. Haploidentical transplantation, in fact, has been used in a number of places. Often these babies with SCIDs have what's called maternal engraftment. So if you look at the baby's lymphocytes, you can see some of the mother's lymphocytes or the residual lymphocytes that you see in some of these severe SCIDs, in fact, are the mother's. So it would make sense, in fact, to do a haplotransplant since the mother's lymphocytes are in there in the first place. You can use peripheral blood stem cells, but there's a reluctance to give GCSF in Europe to young donors, so they're pretty much using bone marrow and cord blood, and obviously there is the risk of chronic GVH, and since this is a non-malignant condition, nobody wants GVH anyway, we certainly don't want it in this one. And obviously unrelated donors have been used, and marrow is still the preferred donor source, but that is changing. So those of you that are old enough in this room can remember the pictures of David Vedder, who was the boy in the bubble and featured on People magazine or something, Life magazine. And he actually lived to the age of 13. He lived in this bubble for quite a while. He came out and then he eventually died. So SCIDS, as I said, is a multitude of disorders. The usual one is our absence of T cells, B cells, and NK cells, but as you probably know, for those of you that transplant them, there are missing certain ones, so you don't have to have all 3 cell lines missing. We know it occurs in 1 in 50,000 to 100,000 live births. At this point in the United States, I believe just about every state has passed legislation for newborn screening, although it is not implemented in every state. So now that this legislation has been passed and the screening is starting in states, you will see more kids coming to transplant because they won't hopefully die before they get there. SCIDS is usually lethal before the age of 2, but there are exceptions. And I talked about the newborn screening, which is going to pretty much change everything. So we want to try to diagnose and transplant before the infections start, which is why newborn screening is important. And depending on T and B cell numbers and NK function, no transplant conditioning may be needed. Now, if you came to some of the talks the other day, there are some centers that even for these kids that others might do no ablation are getting fully myeloablative therapies. So I would say that in the pediatric immunologist population across the world, although reduced intensity transplants or no chemotherapy is the way to go for the majority of these patients, there are clearly still some centers or some situations where fully myeloablative chemotherapy is being given. So more about that in the years to come as we get a better database. Haplos T cell depletion is possible for all patients. A family member or NMDP donor cannot be identified. Those of you who have done haplos with T cell depletion know that B cell engraftment might never happen. They might lose it, or it might be very inefficient, and supplementation with IVIG for the rest of their lives might be possible. We have also seen patients who had T cell depletion who lost their entire graft 20 years later. So this chronic level of graft rejection and late graft loss is really very, very fascinating. So if you look at the outcomes of SCIDS in this nearly 30-year time at Duke, you can see that there are, in fact, later deaths. Now, some of these deaths really can be are caused because of graft failure. There are not really second malignancies in this group, but obviously, in these days, the outcome is much higher. Now, if you look at this transplant consortium in Europe, and if you look at HLA identical transplants for SCIDS, you can see that they were reporting 100%. And then even when you took HLA phenotypically identical ones, there was a few that they did pretty well, and their haploid ones did not fare quite as well. But in the hands of many U.S. centers that do haplos, the survival is much better than that. So I'll switch to HLH. I think any of you in this room who is at a pediatric center has seen more cases of this than you would like. It's really a fascinating disorder. It's an immune activation of macrophages. It's a dysregulation with reduced T and NK cell cytotoxicity. And this leads to lymphocyte accumulation and mature macrophages, which have extremely destructive behavior. So this is really a disorder of poorly behaving macrophages. The familial disorder or primary HLH can usually be identified by the MUNC13 or perforin gene mutations. However, there are clearly hereditary cases where these genes have not been identified and we don't know what the other genes are. And there's also these sporadic conditions with secondary variety of triggers. EBV can do this. Some patients with Griscelli syndrome have this. There's a whole long list of diagnoses. And those of you that might see some adult patients know that some of the adult lymphomas can present as HLH. So the secondary HLH that I was talking about can be due to EBV infection, leukemia, lymphomas, and some rheumatologic disorders. Now, we really don't see this much in pediatrics with rheumatoid arthritis and SLE, but it has been reported. But in the adult population, and possibly because of the immunosuppression or monoclonal antibody treatments that they have undergone, they're seeing some HLH. In these cases of secondary HLH, so I can stand up here and I can say if it's a secondary case of HLH, you should definitely treat the inflammatory state first and then the malignancy or the rheumatologic disorder. But often when you are faced with these patients, you don't know the chicken versus egg, which came first. So it may not be totally obvious what you're treating first. So for those patients that have the secondary, if you can treat the underlying malignancy or rheumatic disorder, then often the HLH will not resurface. However, obviously sometimes it does progress even with successful treatment of the underlying disorder, and for those patients, even adults, just like the pediatric patients, then transplant is the way to go. With the primary treatment of HLH, the first thing to do is obviously make the diagnosis. I think that everybody in pediatric centers has gotten a lot better at making the diagnosis, and thanks to Lisa Filipovich's lab in Cincinnati and a few other places around the country where you can send your samples and get an answer very, very fast about the granzyme B, perforin gene, MUNC gene mutations, etc., you can actually make this diagnosis. The backbone of the initial therapy is etoposide, cyclosporin, decadron, and intrathecal methotrexate if there's CNS involvement. Some centers have just used ATG and corticosteroids and gotten similar results, although this is not as common. So the goal, as I said, is to decrease the inflammatory state. If it's primary HLH and you decrease the inflammatory state, that's great. If you don't transplant, it's coming right back. So the diagnosis is based on now standard international criteria, so you can have a molecular diagnosis with these variety of gene mutations that are up here, but remember, not everybody with a true HLH is going to have one of these gene mutations that is identified. So there's criteria of the fever, splenomegaly, cytopenias, hypertriglyceridemia, hemophagocytosis in the bone marrow, spleen, lymph nodes, or liver. Although I should say I've never seen a pathologist who's willing to make that disorder based on hemophagocytosis alone. Looking at NK cell activity, which should be low. Usually these people have hyperferritemia, and you can get elevated surface CD25 expression. This is a nice algorithm that was published in Blood several years ago about when you have a clinical suspicion of HLH, which is easy in the pediatric population. In the adult population, it's often confused with something called macrophage activation syndrome, which is going to be treated somewhat differently. Anyway, I'm not going to go through this entire algorithm. The slide deck should be available. But or you can go to this reference, and I think the algorithm may be helpful when you don't have a case of primary HLH, because I think, does everyone in this room know what to do with primary HLH? I would think yes. Treat, transplant. The treatment of the secondary HLH is going to be chemotherapy for malignancy, immunosuppression for the rheumatic disorders, Rituxan or anti-EBV therapy, perhaps cellular therapy. And it's the minority of these adult patients who actually need a transplant. Now moving on to Wiskott-aldrich syndrome, which is really a fascinating disease. It's an X-linked disorder with an incidence of about 10 per million, so extremely rare. It is not screened for on most states' newborn screening. It usually presents in the neonatal period, and they almost all have thrombocytopenia, and the board question is thrombocytopenia with small platelets or a low platelet cell volume. The platelets are also very dysfunctional, which means that they have a severe risk of bleeding. They also have decreased lymphocyte function. So these kids have eczema infections. They also have autoimmunity, which can be a problem during transplant, and lymphoma. These are the kids in transplant that have more CNS bleeds than any other transplanted group of immunodeficiencies. The only effective therapy is transplant. If you look at the survival curves with matched sibling donor, it's quite respectable at 80%. When you get to unrelated donors and mismatch-related donors, the survival is not quite as good. So clearly with Wiskott-aldrich syndrome, our survival is not as good as with the severe combined immunodeficiency. But remember that SCIDs don't present with thrombocytopenia and have the problems with bleeding, and these kids clearly do, plus the problems with autoimmunity, and that is why the survival curves are less. If you look at patients treated in Cincinnati that was published several years ago, you can see that in their more modern curves, they're still getting somewhat less than 80%. So I would venture to say that at one of the best transplant centers in the world for immunodeficiencies, they're still not getting curves that are similar to SCIDs. And that's just an inherent problem with the disease. And if you look at some of the survival curves that are up here for the most modern ones that are transplanted less than the age of 2 years, that they do better. So the thing with Wiskott-aldrich is they may not all present as neonates. Basically, the younger that you transplant them, the better they do. But you have to make the diagnosis. Now, I think all of you have seen some patients with severe congenital neutropenia. Kostman syndrome is just one subgroup of that. It's actually a very diverse group of disorders where generally the absolute neutrophil count is less than 500. The most common problem is recurrent bacterial infections. It's rare also, with 1 to 2 cases per million births. The genetics is all over the place. It's important to know that G-CSF actually makes most of these disorders go away. So why don't we just use G-CSF? That's pretty easy, especially with pegylated G-CSF. You just give it, once every few weeks, and the kids are fine. Well, it's the last line, and I don't know how many of you are aware of this, but there's a 22% chance of getting AML-MDS after 15 years of G-CSF treatment. So that doesn't mean you should treat every child with severe congenital neutropenia immediately when you see them, because G-CSF will make them better along with other supportive care measures. But these patients do require bone marrow aspirations with cytogenetics and flow cytometry at least every year that they are on G-CSF therapy. And I should also point out that there's a few children with one of these disorders that does not improve the G-CSF therapy. And there's probably some autoimmunity in that. So obviously transplant is curative, same issues as everything else with donor location and identifications. So if you look at some transplant outcomes that were published a few years ago for severe congenital neutropenia, you can see that the overall survival with mismatch-related donors is not great in this one series, but there were only 3 patients. We know that with mismatched unrelated donors, especially if you use cord blood, it's clearly better. But the outcomes are generally in the 90% range or higher. Obviously, chronic graft-versus-host disease is an issue for some of these patients, which is not really very helpful in this disorder. Most patients who fail a transplant and don't engraft can get another transplant. So chronic granulomatous disease. So within this is somewhat less common. This is a disorder of neutrophil function or phagocyte function. And these patients not only have recurrent bacterial and fungal infections, but they also have granuloma formation in their lungs, GI tract, skin, and others. There are various degrees of severity of this. There are definitely adults that are alive and doing reasonably well, and there are some kids that die at a fairly young age. It's autosomal recessive or X-linked that is not screened for in any newborn screening tests. Basically what happens, you have poor NADPH oxidase activity, so they can ingest the bacteria or the fungus, but normally your granulocytes are able to kill it, but they're not able to kill the bacteria and fungus that they ingest. There's a 2 to 5% annual mortality, and transplant is definitely for those that are more severely effective, and those of you that see a number of these patients in your clinics realize that some kids don't do very badly at all, and some kids are sick all the time. So there are options for treatment here. Transplant is certainly one of the options that have been used. The survival rate is reasonably good post-transplant. The numbers are not huge because the numbers of patients with CGD that probably qualify for transplant are not huge either. But it's certainly a viable approach. I just wanted to take a minute to talk about some special supportive care hints for patients with immune problems. So the first thing I'm going to say is every center does it differently. Every center has very strong beliefs of what you should do with these patients. And those centers that transplant a lot of these children and have good outcomes, whatever their cocktail is of supportive care is not necessarily translatable in another one. So what most people agree on is that pre-transplant testing for respiratory viruses, EBV, CMV, HHV6, and others is really important. You would certainly, now if somebody had skids, you're sort of trapped is when you take the transplant. But for some of the other disorders with a more elective transplant, you don't want to take someone with an immunodeficiency that has newly diagnosed RSV and transplant them. I think that's fair to say. Those patients are more susceptible for infections. So some centers believe that gown, glove, mask for all patients entering the room, including family members, is absolutely mandatory. How many of you are at centers that do that? Raise your hand. Okay. And how many of you are at centers that transplant kids with immunodeficiencies do not require this? Okay. So this very strong recommendation by some of the larger centers is certainly not universally followed, and we can understand why. Most people believe that weekly EBV, CMV, and adenovirus PCR testing is very important. I know some centers that do it twice a week. Now, some of you are saying, well, there's not much we can do about this. Well, certainly there's something we can do about CMV. I think that cidofovir is reasonable treatment for adenovirus and certainly Rituxan for EBV. But as the antigen-specific T-cell therapy directed against all these viruses is going to become into more common use, probably you will see these T-cells, off-the-shelf T-cells, available at most centers across the country within the next 5 or so years. So you do want to know if someone's infected, because if they don't respond to the usual pharmacologic interventions, then this T-cell therapy will be very important. Now, weekly IgG levels with active supplementation. Now, in talking with a number of centers, some centers give so much IVIG you think that their centers have stock in the company. And some centers follow weekly IVIG levels and supplement intravenous gamma globulin when there's hypogammaglobulinemia, and some centers don't care. So if you look across the country, there's not a huge difference in outcomes between the centers that are using these various practices. So I put this up here more as an interesting controversy. How many of you give IVIG all the time no matter what? How many of you do weekly levels and respond to the levels? And how many of you don't do it at all? Okay, so nobody was brave enough to say they don't do it at all, but we know there are some centers out there that don't do it at all. And vigorous adherence to prophylaxis, I think that everybody does that. We all know the prophylaxis that these patients need. They're generally in hospital for the whole time of their recovery, so that's pretty good. The general caveat is younger patients equals better survival. Newborn screening for all these disorders would really be helpful, but we think that, as pediatricians, we were pretty good at getting newborn screening available at all in the United States for these disorders. So obviously infections post-transplant and the risk of viral infections is really important. And just like all the other ones, until you have full T and B cell recovery, you're going to see increased infections. So whatever you need to do to screen, prophylax, educate your families about all this. I was just talking, with one of my colleagues from Montreal who, after the kid was in a transplant 2 months later, there's a picture of the kid out with some backhoe in some field in the summer in Quebec, and, he's dead a month later of rhizopus. So constant education about what they should do is probably very important. Additional post-transplant problems that all of you are probably aware of is autoimmune hemolytic anemia, which is seen in a number of these patients with immune deficiencies or disorders of immune regulation. Also, immune ITP is going to happen. Hypothyroidism is very common, and you should remember to screen for that. The hypothyroidism is more common in this population post-transplant than it is in our leukemia population post-transplant. And obviously, vasculitis or transplant-associated microangiopathy is important as well. The increased risk of bleeding is a sort of concurrent thing that happens during the transplant with Wiskott-aldrich patients. Most centers try to keep the platelet count above 50,000, but good luck because they got antiplatelet antibodies. So these patients are often getting a lot of platelet transfusions. And interestingly, in all the immunodeficiencies, bronchiectasis is more common post-transplant, even if they never get bronchiolitis obliterans syndrome or BOOP. So for whatever reason, bronchiectasis is more common. It's more common in the older kids that get transplanted. Perhaps it is secondary to the fact that they had pre-transplant lung injury due to infection before the transplant even started. But obviously this is tough to figure out. So in conclusions, transplant provides lifelong cure for most immunodeficiencies and disorders of immunoregulation. Early diagnosis is really critical. Special expertise is needed for pre, peri, and post-transplant care. And gene therapy, as we heard about with sickle cell disease and thalassemia, may one day replace transplant for these disorders. I think all of you are aware of the gene therapy that was used for ADA deficiency 20 years ago. Unfortunately, the way they did it, the majority of those kids ended up getting leukemias and dying from their leukemias. The newer gene therapies are much safer and seem to be pretty effective, but those are obviously very much in the experimental period. So I appreciate your time, and thank you for letting me substitute for Lisa. So thank you very much.